you get a coloboma of the optic nerve, and it's inferior to the nerve. And so basically what you see here is why is that all white? Sclera. And so basically the choroid and all of the tissue in the retina just doesn't form in that area, so you just get bare sclera. And it's inferior to the nerve, and you see this large area, so you get what's called an optic nerve coloboma. So that's when the posterior choroidal fissure fails to close. All right, now this just shows you again a schematic of the crystalline lens. So remember, it's surface ectoderm that pinches off, and then as that invaginates and pinches off, you get a circle here with the lens epithelial cells there. And so then what happens is the cells posteriorly will migrate anteriorly and go along the equator, and those will send fibers out that form the lens. And so that's how you go from a cyst to a solid lens. Now the reason that that's important is after this stage of embryologic development, there is normally no lens epithelial cells along the posterior capsule. They go to the equator and then they fan out. So when you look at a crystalline lens, in an adult or even in a child, then there are no lens epithelial cells posteriorly, unless there's something pathologic going on. And this just shows you that again. Here's the anterior lens capsule, the lens epithelial cells, they go to the equator, and then they fan out along the equator. We call that the lens bow. And then they send fibers anteriorly and fibers posteriorly that form the crystalline lens. Now that lens is forming throughout life. So when it first starts, it's almost like a sphere, but as time goes on, it becomes a little bit more oval shaped. And it gets denser in the center and it gets thicker as we get older. And here you can see, there's the lens pinching off, there's the lens vesicle, and finally forming the lens embryologically. So this is an eye that has undergone all this. This is an actual embryo. I believe this was about 20 weeks. Here you see the rudimentary eyelids forming, conch, cornea, crystalline lens, and then anteriorly these two layers will form the iris pigment epithelium, ciliary, and then retina and RPE. And all of this tissue right here is neural crest, not mesoderm, because it goes in there in waves. All right, now, the nourishment of the eye. We talked about as the eye is forming, the hyaloid artery comes in and it gives nourishment to the lens as it's forming, to the whole anterior segment of the eye. And basically it forms a vascular tunic, tunica vasculosa lentis, literally a vascular tunic around the lens. And that helps it to develop. But as the eye develops, then the hyaloid artery system should regress. And so if it doesn't regress, we have a persistent hyaloid artery, and that's an abnormality. If you look right here, this again is an actual human eye. Here we've got remnants of the hyaloid artery coming from the optic disc forward, and then you see this little vascular network it forms around the lens. So that is persistent fetal vasculature, and so that has not regressed. That hyaloid artery should normally regress, and in this case it hasn't. And so here it is pathologically. This is the crystalline lens. These are those little vessels that form that little vascular net around the lens. All right, questions about embryology? Yes?
So the sclera doesn't come from the neuroectoderm, right?
That's the one part. Well, there's part of the temporal sclera that comes from mesoderm, but a lot of the sclera still comes from neural crest.
Okay.
Yeah, good question. Yes?
I also want to know what parts of the eye come exactly from the neural crest.
It's the stroma of the cornea, it's the substantia propria of the conjunctiva, and it's most of the sclera. Most of the sclera. So it's what you think of as stroma or mesoderm. Okay. All right, we're going to talk a little bit about inflammatory cells too, because this is the only chance we get to do them. And I wish I could say I made this slide. Now, if any of you guys remember hematology, I don't think I've ever seen a single microscope slide that has all of the different, white blood cells. And so I don't know how they did this. This was from the era, this slide is from the 1960s. So this is from the era before there were computers. I have no idea how they made this slide, but it's pretty cool because it shows you all of the basic white blood cells. And so what we're going to do, we're going to go ahead and we're going to talk about each one and kind of what they do and how to recognize them. So we're going to go ahead and we're going to start right here, just looking at this at low power. What kind of cell is this?
Neutrophil?
Okay, or people may call it PMN, polymorpho neutrophil, PMN. All right, what kind of cell is this one right here? I'll go to the back there.
Basophil?
Nope.
Eosinophil?
Eosinophil, exactly. So eosinophils are pink. They've got kind of a bilobe, heart-shaped nucleus and all these little pink granules. What is this? Basophil. See, that's the easy one. Get that. Now you can hide back there, but you can't hide. I can still see you. Which cell is this?
The lymphocyte?
Lymphocyte, exactly. And now these are all to scale, which is what's interesting on this slide. And then, all righty, so and these are just red blood cells, just to kind of show you the scale. So we're going to talk a little bit about each particular one. All right, so we talk about a PMN. We'll just kind of keep coming around. We'll start here. So what does a PMN do?
It's like your first line of defense. It releases secretory granules that just kind of occur in the acute response of an infection.
Okay, so exactly. So PMNs are the acute inflammatory cell response. And you said that's kind of the first line of defense when you have, invader, bacteria, foreign material, whatever. And if you look at these PMNs, polymorpho neutrophils, so you've got multiple nuclei in there, but all of these are secretory granules. And those secretory granules have proteases, collagenases, they've got all kinds of things in there that help to fight off an invader. But in the eye, especially in the cornea, those aren't really good cells to have around because they dump out all this material which melts cornea and melts the stroma and causes all kinds of problems. And so that is why if you've got an acute bacterial corneal ulcer, that's an emergency because you want to shut that down not only before the bacteria causes damage, but before the immune system causes damage. So this is kind of our first line of defense, PMNs. And oh, that's not good. We are not advancing. Boy, we are just not having a good day today with this computer.
I know.
Just stop in the middle. I guess we can try that. Okay, well, I'll have to use that, and that's okay. We can do
Just
that.
try your clicker again.
Okay, let's try that again. Oh, there we go. Okay. All right, so eosinophils. What do eosinophils do?
They release histamine and cause an inflammatory response in the allergy.
All right, so they're kind of the cell that really does allergies. And so if you look at them, you've got this bilobe nucleus we talked about, and then you've got all these little eosinophilic staining secretory granules. And so when you think of those, you think of an allergic reaction. You think of what it does when an allergen is seen or is spotted. These just show you what eosinophils look like in an actual smear. And once again, they've got that kind of pink cytoplasm, eosinophilic staining, and then you've got that kind of bilobe nucleus there when you look at a real one. All right, lymphocytes. What do lymphocytes do?
Lymphocytes, they're involved in fighting infection, fighting cancerous cells, in producing antibodies.
Okay, so when you look at lymphocytes, they're kind of involved more in a viral infection, but they can be also, they're in a bacterial infection. And then also they can be involved in other things that you want your inflammatory system to be alert to. So when you look at a lymphocyte, the interesting thing is you see that the nucleus makes up about 90% of that. And it's got just that little crescent of cortex there, so that's how you know a lymphocyte. Now there is a specific type of lymphocyte called a plasma cell. What does a plasma cell do?
Make antibodies.
So this is an antibody factory. So it's kind of a B lymphocyte that's even progressed further along down the line, and so it makes a plasma cell. When you look at the plasma cell, the nucleus is eccentric. It takes up about a third of the cell, and then the cytoplasm is 2/3. And you see, now pathologists have good imaginations because we tend to, live in the basement. Pathology labs are usually in the basement. They're poorly ventilated. We sniff a lot of formalin. And so they call this wagon wheel clumping. So if you really hallucinate, you've ever seen like the covered wagons and they've got the spokes coming out of the center? So they call this wagon wheel clumping. So yeah, I can see that. So our path lab is really rare. We're on the 3rd floor and we have, on the 4th floor, and we have windows and good ventilation. And so I guess we just don't get enough of the formalin fumes to hallucinate well. But when you look at these closer, you see that little pale area right next to the nucleus, and that's where all the Golgi apparatuses are. And they're the manufacture of proteins. So really, plasma cells are like an antibody factory. So they're making the antibodies that you think of in an inflammatory cell reaction. And the ultimate one is eventually these cells get so big and they get so full of the antibodies that they're making that they extrude their nucleus and you're left with what's called a Russell body, which is basically a sack of antibodies. And so that's, again, kind of the end stage of a plasma cell. All right, monocytes. What do monocytes do?
We're also involved in fighting infections. They eventually can turn into macrophages.
Okay, so when they get out of the blood vessels, they turn into macrophages. Now, if you want to sound really smart, you should say something with a British accent, because I don't know why but you say macrophages, and it just sounds nicer, it's like macrophages. And so when you look at them, they're monocytes that go into the tissue, and this is a whole field of macrophages, and they've got this pink cytoplasm around them, and eventually macrophages can turn into giant cells. So I'm going to talk a little bit about granulomatous inflammation and talk about giant cells. So what we're going to do, what I want you guys to take away from this is there's 3 major types of giant cells, and there's also 3 types of granulomatous inflammation. All right, so we're looking at the first one. What's a Langhorne type giant cell? What does it do? Or what's it involved in?
Chronic inflammation.
Yeah, so it's kind of the chronic inflammation that's going on. So when you've got a chronic granulomatous inflammation, what you see is you see a classic Langhorne type giant cell. When you look at these, the nuclei line up around the edge and it's shaped like a horseshoe. So it's kind of a U shape, and the nuclei line up around the edge, and then the cytoplasm all coalesces in the middle. So that's the Langhorne type giant cell. And here's what a Langhorne type giant cell looks like right here. You see it's forming a horseshoe with the nuclei coming around the edges and then the cytoplasm in the center. We call them giant cells because, compared to normal lymphocytes, they're really giant. They're very big. And so that's a giant cell that you see. Now, foreign body giant cells, how are they different than the Langhorne type giant cells?
The nuclei of a foreign body giant cell are more jumbled.
Exactly. So instead of forming that horseshoe around the edge, they're jumbled up in the middle. And so a foreign body giant cell literally can form against a foreign body. And you think about it, there can be foreign bodies in the eye that get in, from any kind of trauma or something, but even a suture is a foreign body. And so you'll get a little foreign body giant cell that'll wall off where a suture fragment is coming into the eye. And so if we look, sure enough, there's a suture, monofilament suture, and there's the foreign body giant cells kind of cuffing around it, walling it off. So they'll form against any foreign material that's in the eye or around the eye. So that's a foreign body giant cell. And now the third type of giant cell, what is that? Actually, we'll go back there. Just sweep across. This is called a Teuton giant cell, T-O-U-T-O-N. And now these are different because you see the nuclei line up in a circle, but you see that little white foamy looking material? That's lipid around there. So these type of giant cells, these Teuton giant cells occur in juvenile xanthogranulomatous inflammations, juvenile xanthogranuloma, the iris, things like that. These are the rarest of the giant cells. And so they form in those particular entities. So Teuton giant cell. All right, so now we've got three different types of granulomatous inflammation. So this is an example of the first type. And we call this diffuse granulomatous inflammation. And the classic example of a diffuse granulomatous inflammation is in sympathetic ophthalmia. What is sympathetic ophthalmia?
That is when we get a reaction in the other eye. And the first eye is affected
Okay,
by
so
response.
So the key thing here is you have something, for example, let's say you have a trauma to one eye, and then the body starts reacting to that, and it really revs up the immune system, and then you almost get an autoimmune reaction to the other eye. This is called sympathetic ophthalmia. So in the days before we had corticosteroids, especially during, World War I, particularly brutal thing, shrapnel would blow up in people, and then their one eye would get damaged, and they'd take care of that, and then a week later, the other eye would get inflammation severe, and they'd lose vision, they'd go blind in both eyes. And so now, of course, we have steroids, we really take care of traumas before you can set up this sympathizing reaction. But what you see is you see a diffuse granulomatous inflammation. So you see here in the choroid, there's lots of lymphocytes, but there's also giant cells in here. Okay, and then there's a second type of granulomatous inflammation. And what type is this?
Nodular.
Nodular type. And what's the example of a nodular type?
Sarcoid.
Sarcoid, exactly. So, sarcoid is one of those things that can cause anything. And so you're never wrong when someone says, well, what's the differential diagnosis? Well, it would include sarcoid. And nobody's going to say, no, I can't be sarcoid. They'll go, oh, yes. So when you're thinking of what the proper answer is, you can say, well, sarcoid. And then the attending will pause for a second and go, well, yeah, you can have sarcoid. And so that's kind of a nodular granulomatous inflammation. And so when you look at this, you'll see that it forms these kind of circular nodules, but right here in the middle, you've got a really big giant cell, and you've got these what are called asteroid bodies in here. And so that's a tip-off for sarcoid. You get these, and again, I don't know where asteroid comes from. I'm not sure what that is, but again, we're sitting in the basement, no ventilation, asteroid body, say sure. So this is that granuloma that you see in a nodular type granulomatous inflammation. Sarcoid is the example. All right, and then you get a third type. This is called zonal granulomatous inflammation. So this is a good example of that. This is lens fragments, which can then stimulate a granulomatous inflammation. So in what setting would you get that?
Like a really traumatic cataract surgery.
Yeah, or just trauma involving the lens in general. So say, for example, you have a severe trauma, you have an automobile accident, you're unrestrained. The last one I saw like this, the guy was pushing a horse up into the trailer, and the horse didn't like that. Boom, kicked him. And so you have a trauma, and you can actually rupture the crystalline lens, and then it'll stimulate that granulomatous inflammation around the remnant lens capsule and cortex. In the initial days of cataract surgery, when we went back to extra cap, and we're going to talk a little bit about history of cataract surgery, but basically in the 1920s, there was no microscopes. They were crudely tearing open the capsule and trying to get the lens out. You would get a lot of raging inflammation around the lens capsule. But then after that, we started to go to what's called intracapsular surgery. So for several decades, we just popped the entire lens out and just remove it inside the capsule. And then it was only in the late 60s, early 70s, we started going back to extracapsular surgery where we would leave the capsule intact, because that was when intraocular lenses were developing. So once again, microscopes were just coming into use. We weren't very good at it. And so we saw a resurgence of inflammation associated with the crystalline lens and leftover cortical material. And so when you look, this was literally the gentleman who got kicked by the horse. And this is remnant crystalline lens right here, and huge amount of inflammation around the lens. And when you look closer, it will form these giant cells. So it's a focal granulomatous inflammation. So remember, diffuse, sympathetic ophthalmia, nodular, sarcoid, and then focal, like ruptured lens. So those are the three types of granulomatous inflammation. And remember the three cells: Langhans type giant cells, foreign body giant cells, and Teuton giant cells. So know the three different types of cells, and the 3 different ways of inflammation. Now, there's no time during all these lectures of pathology that I get a chance to show you what's happening here, and this is kind of an end stage. Yes?
What was the context that Teuton cells form again?
Teuton is like juvenile xanthogranuloma. So it'll be xanthogranuloma disease like that.
Thank you.
And so you see a little, that's always on boards, you see a child with spontaneous hyphema. There's definitely not been any trauma that they know of, and then the kid just forms a hyphema. You look at the slit lamp and you see these funny, fluffy areas on the iris stroma, and that's the juvenile xanthogranuloma.
Thank you.
All right, so this is an eye that's had a long-standing vitreous hemorrhage. And when you look at it, you can see broken down red blood cells in here, long-standing vitreous hemorrhage. And I want to show you what the end stage result of an eye is after anything, like a long-standing retinal detachment, inflammation, trauma, when the eye shuts down. And what do we call the end stage of an eye when it shuts down?
Phthisis bulbi.
Phthisis bulbi. And it's important when you look at it, it's spelled P-H-T-H. So, phthisis. And so you just say it like a T. So you say phthisis, and that's just easier to say. So that's kind of the end stage. And so the first thing that you notice, what do you see that's funny about the shape of this eye? What do you think about the shape there?
It's not around.
Yeah, it's not round, it's almost square or rectangular. So it really loses its nice firm round shape. What is this tissue right here?
Sclera.
Sclera. What do you think of the sclera there?
Thick.
It's really thick. And so the sclera thickens. And when you look at these eyes, you can't tell, I didn't put a measuring stick on here. These are smaller than normal. So as the eye shuts down, the ciliary body shuts down, it stops making aqueous, the eye becomes hypotenuse. So you put your tonometer on there and the pressure reads 0, instead of 15 or 20. So the eye gets hypotenuse, and as it shrinks, the sclera becomes edematous, it thickens. So you get thickened sclera. What is this layer right here? That's the choroid. And what do you think about the thickness of the choroid? Yes, it's really thick. So as you get hypotenuse, that choroid's almost like a sponge. It just soaks up fluid and expands. And so the choroid gets markedly thickened. And the other hallmark of phthisis bulbi is you get, loss of normal architecture of the intraocular contents. So it gets really jumbled up. If you see right here, this is what's left of retina, jumbled up. This is what's left of lens. And so you really get the intraocular contents. You lose that normal structure, the normal things that you see. And here's the thickened sclera, very edematous, very thickened sclera because of the hypotony. And here's the choroid. Again, very edematous, very thickened choroid. What the heck is this stuff? Right here. Give you even a higher power view. There it is. What is that?
Excuse me, where was it?
What's that?
Where in the eye was that?
It's along where the retinal pigment epithelium used to be. All right? Enunciate it. What is this? Go ahead, say it. And it's okay to say I don't know. I mean, so you don't know. I'm not sure what do you think this is?
It's bone. You can see some lacunar spaces.
Yeah, it's bone. And so an end-stage Phtisical eye, the retinal pigment epithelium is kind of a pluripotential cell. And so it can form all kinds of tissues, but stimulated in the right way, it can start laying down bone. And so when we get these Phtisical eyes in the clinic, you go to cut these, and man, it's like cutting bone because it is bone. And so my technician has to decalcify these for several days in order to be able to process it and cut it. And so end-stage Phtisical eyes will form bone. And so that's interesting because really normally you don't have bone inside the eye. So that's very unusual. All right, now again, because I've got you guys here early in the year, I want to let you know this because you're going to be working in the OR eventually. And for the first years, you guys might say, God, I'll never get to the OR. All I do is see consults and calls. Eventually you'll get to the OR. And so, especially when you're doing your plastics and your orbital rotation, but also even cornea, you'll often remove tissue and you'll want to send it to our laboratory and say, hey, is this tumor? Is there something else going on? And so I really want to emphasize the fact that you should communicate with the pathology laboratory ahead of time. And the perfect example for us is the ocular plastics people. They'll often fire off an email to me and say, hey, we're doing a case on Tuesday. It's potential this. Can you please do this stain? And that's really helpful. The other one, Dr. Who, is fabulous. She gets big attaboys. She'll send me a detailed email ahead of time all the time, and that's so helpful because it allows us to plan ahead of time as to how we're going to be, doing that tissue analysis. And so let the pathologist know ahead of time what you want done and what you're suspecting. So communication is critical. And so there'll be a requisition slip. And what you want to do is the more detail you can give us, the better it is. And so you don't have to give us a whole, 2-paragraph history. All you have to say is, recurrent leukoplakic lesion, suspect squamous cell or CIN. And that really helps us. The other thing is if you've got something that you want to localize, say, okay, temporally this looks suspicious, nasally it doesn't, draw a picture. And again, I don't expect you guys to be artists. You can draw just a crude picture saying, okay, here's the temporal conjunctiva, here's where we think the lesion is, because any information you can get us is very helpful. Now, when you handle the tissue, you've got to be really gentle. And it's really hard because, you guys first start, you got to grab that thing and really grab it. And so you can do what's called crush artifact. And that will actually damage the tissue. So you want to be very gentle with it. If you're suspecting a tumor, you want to go ahead and get a rim of what's apparent normal tissue to you around the tumor to send it to us so we can make sure it's normal around there. And then fixation. You want to fixate it promptly. And so what we normally use for the vast majority of cases is 10% neutral buffered formalin. So that's what we do standard. But if you want to do electron microscopy, very rare, but sometimes we do it, you want a glutaraldehyde-based fixative. So again, talk to us, we'll get it to you. Now, sometimes people want frozen tissue to look for margins and look for other things. So frozen, again, you gotta let us know because we need to have fresh tissue. And so when you're submitting something for frozen sections, do not put it in formalin. Take a sponge, like a 4x4, a sponge, moisten it, and then put the specimen on that, and then put that in the container, and call us immediately. Because the worst thing is you're in ocular plastics Friday at 5 o'clock. You want a fresh specimen, you hand it to the nurse puts it in the box. We come in Monday morning and find it, and therefore it's been sitting there unfixed for 2.5 days. So call us ahead of time if you're going to send fresh tissue. All right, and if you're from the outside, say someone's in Montana, they want to send us something, you can actually put it in a moistened chamber and put ice around it and send it in a in a stat mail, and it will get to us in 24 hours. That'll keep it too. All right, conjunctiva. I always want to talk about conjunctiva because if you remove conjunctiva, it curls up in a ball. And you don't want to go ahead and just send that ball if you think there's a tumor. And so what you want to do is you want to lay out the conjunctiva so that we can look at the margins. And so the best thing I find is a little piece of absorbent paper or cardboard. And what works really well is when you spin the gowns, you hand that little cardboard to the nurse, one surface is shiny and the other surface is kind of rough and unfinished. You can actually use that to fixate the conjunctiva, and it works really well. So you cut a little, say, 2x2 centimeter piece of that cardboard, and you lay the specimen out on it, and you let it sit there for about 30 to 60 seconds, and it will stick. Then you float the whole thing into formalin, and that'll keep that oriented. And then what you can do is you can go ahead and if you want to look at margins, say, okay, we're really worried temporally, don't try to pin it to a surface because that falls off. If you use standard ink, that dissolves. And so one of the things we find is if you get it to stick to the cardboard, cut a notch in the cardboard and say, okay, temporal is 1 notch, superior is 2 notches. And we can run that through and then orient it. Here's that little piece of paper, little piece of cardboard. There's the conj laid out beautifully. There's the notch saying temporal. And that will allow us to go ahead and to look at these and see how well fixated they are. All right, one last thing here we're going to talk about is stains. A little bit about stains. Now, I'm talking a lot today. Normally, we don't do that. So again, when we get in November to these actual subsections of the eye and pathology, you guys are gonna do all the talking. But this one, you know, I have to do the talking. So what's the most common stain we use? What's the standard stain?
H&E.
H&E.
H&E. So again, speak up. I'm sorry, I can't hear you up here. H&E. What does that stand for?
No idea.
Okay, hematoxylin, eosin. So the hematoxylin is kind of the blue part of the stain. The eosin is the pink part of the stain. So that's your standard stain. That's the vast majority of ones we do are hematoxylin, eosin. And here's a cornea with an H&E stain. Now, this is a specialized stain, and this is trying to highlight something right here under the corneal epithelium. What do you think this stain is?
PAS.
PAS. And what does PAS really highlight that we like to use it for?
Basement membrane.
Basement membranes, exactly. So if you're looking right here, here's the epithelium of the cornea. Here's the basement membrane, this little line right here now. Remember, Bowman's layer is not a basement membrane. Basement membrane is this little line here. So PAS stain will stain a basement membrane this kind of bright magenta pink color. And so PAS, if you want to look at basement membrane, lens capsule, Descemet's membrane, those are all basement membranes. So PAS will stain those. All right. Now, there is 3 different types of there are 3 different types of corneostromal dystrophies. And so it's important because they highlight 3 of the other stains that we do. And so, and when we do cornea, you will learn the mnemonic. And I want you to look it up before we do cornea. The mnemonic is Marilyn Monroe really always gets her man in LA, California. You're gonna go, what the heck is that? So we'll talk about that in cornea. You'll look it up. But first thing that we do is there's a stain for Alcian blue. And Alcian blue stains what material? You guys know the mnemonic at all?
MA.
Yep, mucopolysaccharide. All right, so Marilyn Monroe, macular mucopolysaccharide, always Alcian blue. So this is Alcian blue and it's staining mucopolysaccharides. How about this one? What do you think this could be? Let's see, you did that. What do you think this could be?
This
Yeah.
one. Just guessing it's Massatic trichrome.
Exactly, so this is Massan's trichrome. And what is this stain?
Clay. Something.
It's granular hyaline. Man Massan's trichrome. So Massan's trichrome stains hyaline, this nice kind of a pinky color. And then lastly, there's a stain that stains for amyloid, and it is called Congo red. So there's a Congo red stain that's amyloid in the cornea. And the cool thing about Congo red stain is if you put cross-polarized filters on there, the amyloid lights up. And so if you're looking for amyloid, Congo red stain, and you could do cross-polarized filters and that'll do that. So when we get to the part talking about corneostromal dystrophies, we'll go over this again, every single one, but it's a good way to remember these 3 types of stains. Okay, now, what kind of stain is this?
GMS,
Okay, and what does GMS stand for?
fungi.
Fungi, exactly. So if you look right here, there be the little yeasty beasties right in there, and they're picking up that kind of silvery black stain. So GMS, gamoid methanoethylene silver stains for fungi. So we use that for fungal stains. And this is an interesting stain. It's kind of green. And so what is this staining? Anybody? Acanthamoeba. And so acanthamoebas are a beast that gets into the cornea. And Gridley, the way you remember that is Gridley stains the stroma green. So Gridley green. So this is the Gridley stain, staining acanthamoeba cysts. Okay, now there are some other stains that we use looking for some specific things. If you look right here, this is the cornea, and you can see all of this blue being picked up in the cornea. So you can't be saved by the page. So what do you think this is? What stain?
Me or?
Yeah.
I mean, Prussian blue?
Prussian blue, exactly. So Prussian blue stains iron. And so I always think of iron tanks, cannonballs and all, and so Prussian blue stains iron. So this is an iron stain in the corneal epithelium. So Prussian blue we use if we're looking for iron. Okay, and then, I don't know where I stopped. I stopped, did that. Okay, coming around here, what do you think this is? And you can say you don't know, and that's okay. Any guesses? I'll give you a hint, it's fresh tissue.
Oil red.
Well, it's oil red O, and this is easy to remember because basically it takes those little O's of oil and stains them red. So oil red O stains lipid, but it has to be fresh. And so this happens to be a cornea, and it's got a bunch of lipid posteriorly here, and it'll stain that. So if you want to do an oil stain, the oil red O stain, you have to have fresh tissue, so it can't be formalin fixed. All right, question?
What's the pathology when a cornea has lipid posterior?
The simplest one is it's actually arcus senellus. And so the corneal arcus that you get is actually lipid deposition. But it's pretty rare that we actually do an oil red O stain because most of the time we know what's going on. Sometimes, for example, a meibomian gland carcinoma of the lid has a lot of lipid in it, and so we'll do an oil red O stain on that. But you do need fresh tissue in order to do that. So you guys are going to forget all this in the next 4 months, but starting in November, we will have a particular topic each lecture. So for example, we'll do orbit, and then lid, and then conj, and then cornea. And so please read that section in the BCSC book ahead of time. And then what I will do is I'm going to show something. I'm going to say, okay, tell me what it is. What are you looking for? What do you think it is? And so I want you guys to talk. This is a rarity because I do all the talking. But next lecture, you guys are going to do all the talking. And you have to sit and see my travel slide. All right, any last questions? All right, great. Thanks for your attention. By the way, 7 a.m., so please be here at 7.